And more importantly, according to feminist critiques of the welfare state, they are tied to a very male breadwinner-centric notion of work. In other words, what feminist critiques of the welfare state are arguing is that while, on the one hand, things are improving for women more generally, the fact of the matter is that we continue to evaluate women's status in terms of work, in terms of a breadwinner model. And the argument here is that that breadwinner model is inherently a male category, one that is still defined by male categories of work. As I've already suggested to you, when we think about the welfare state, we think about it in terms of work and employment. You can't access the welfare state unless you pay taxes. And the only way in which you're going to pay taxes or income taxes is if you're working. And most of the time you get your benefits through your work. Right? You can't file your taxes until your work provides you with your tax information. In other words, your relationship to the welfare state, as much as we like to think it's universal and for everybody, is mediated through work. And it's mediated by your relationship with the labor market. Now, the feminist critique of this very fact reveals some very interesting insights. First of all, most women both work at home and in the formal labor market. That notwithstanding changing family dynamics or changing dynamics in terms of the gender vision of labor within the household, the fact of the matter is that women continue to, by and large, bear the burden of work at home. Cooking, cleaning, childcare. In Canada, we have parental leave for both parents. 80% of that parental leave is still taken up by women. It's by far, very distant from a gender equality division of labor in terms of parental rearing. So women have, in many ways, historically, and it continues to persist today, they continue to play this dual role of work at home and work in the labor market. The fact of the matter is, however, is that this work and labor at home is unpaid. It is technically non-market productivity. Now, if you think about it, you say, well, how do you value work at home? Right? It's not tied to the labor market, but it is. People have cleaning services. People hire caregivers. Right? People have people who work in their homes, which costs a hell of a lot of money. There is a market value, I can assure you, to hiring a caregiver, which we have done. But if it's done within the home, by the woman who occupies that home, that is considered non-labor market productivity. It is unpaid work. Even though it has a market value, women, by and large women who do it at home, are not paid. In other words, then, the welfare state, again, privileges formal labor market work. One of the other consequences of this, then, of course, is wage inequality. Quite simply, when, again, by and large, it's women who are playing this dual role, and part of their dual role is unpaid, the consequence of this is that in formal labor market sectors, women are still systematically paid less than men. In 1984, the average women's salary was 65% of that of men. In 1999, 15 years later, after a period of 15 years of enlightenment and modernization and progress, that ratio had increased from 65% to 72%. So less than 13 years ago, women were still paid less than 3/4 of what men were being paid in similar jobs. You've all heard of the glass ceiling. We know that women tend to exit the labor market more frequently than men, usually for child-rearing purposes, even though we've created those rules now that encourage both men and women to do so. The fact of the matter is that it's women who tend to exit the labor market. take time off. And if you haven't thought this through, what it means is that you and your buddy or you and your colleague may be starting work at the same time, but if you take a year off of work, that colleague of yours, probably a male colleague, will get a raise. And when you come back to work, you will be behind. And if you do that a couple more times, let's say, for whatever reasons, you will be further behind. These are one of the systematic reasons why, despite our best efforts for wage equality, the fact of the matter is that women are systematically paid less than men. This has long-term consequences, the feminist critique of the welfare state would say, because what it means then is that women have a lower capacity for long-term savings. Because again, statistically, women exit the labor market more often. They are not paid for the work that they do at home. Therefore, then, they have less capacity to save over the long term, which means they have less in terms of Social Security and old age income security, which in the end, again, according to feminist critiques of the welfare state, means that women have to rely on the male breadwinner. If you think about this over the life of a worker, this leads to yet another structural inequality over the long term. And what we've actually seen then statistically is the feminization of poverty. When you disaggregate poverty data, you actually see that in both rich countries and poor countries, the majority of those living under poverty or in conditions of poverty are women, both in absolute numbers and as relative numbers. This number here, in terms of advanced industrial countries, says, well, actually the top statistic there is roughly 70% of the world, people around the world who live on $2 a day or less are females. So when we go back and we look at that, whatever it is, 1.3 billion people who live on less than about 25 a day, the vast majority of them are women. And when you look, for instance, here in terms of absolute numbers, you can see that women living below the poverty line in Canada, 2.4 million, 16 million in the US, 12 million in Germany, and the numbers for less developed countries are even worse. The point here is that the welfare state is a set of institutions designed to reduce inequality, but it is also a set of institutions that are institutionally tied to formal work. And because it's tied to formal work, it has a gender bias. It tends to protect those who are employed formally, which are typically men, and it tends to not reward or not protect those who work informally or who are engaged in quote-unquote unpaid work, who tend to be women. So again, when you disaggregate the data along gendered lines, you can in fact see that some of the very institutions that we expect to be reducing inequality, in fact, are exacerbating inequality in both rich and poor countries. Last story I want to tell you is called Beyond the State. We've talked a lot about government. We've talked a lot about the nation state. We've talked about the welfare state as a national intervention or a governmental intervention to reduce inequality or to mitigate the effects of inequality. What I want to talk about now is some work that we're doing that goes beyond the state. To encourage all of you, for instance, to think beyond the state and some potential solutions. One of the places in which we're doing research now, happy to talk to any of you about this during office hours, is in India, in which we have a country in which per capita GDP is a woeful $3,700. Although it's growing, India is still in many ways considered a very poor country. 26% of those blind in the world are in India. We're not quite sure why. But approximately 12 million out of 45 million of the world's blind live in India. Now, you can imagine this is a huge problem. If you are blind, and again, this is one of the things about bearing witness, just hang out with a bunch of blind people for an entire day, you will realize that they suffer enormous human indignity. But if you want to think about it just in purely instrumental economic terms, they can't work. They're not economically productive. There is a statistical relationship, particularly in southern India, between those who are blind and those who are poor. So this is a huge problem that we see in India right now. Here's the other paradoxical fact. 80% of blindness can in fact be cured. Actually, it's very simple. It's a cataract surgery. So what we call this then is needless blindness. 80% of those 45 million people who are blind don't have to be blind. They can in fact be very easily cured through a cataract surgery, which actually takes about 10 minutes. So then why do we still see such a high incidence of blindness? Well, one of the reasons is that the cost to cure is extremely high. It's a 10-minute surgery, but in the United States, the surgeon will bill the insurance $3,000. So now, when you think about it, cataract surgery and going rates in the U.S. and in Canada too is about $3,000 for surgery. You ask yourself, in a country in which the GDP is $3,700, you partly get your answer as to why we still see a very high incidence rate of blindness. There is a hospital that we've done some research on, and we spent a couple of weeks there writing up the case on, which is called the Aravind Eye Hospital, which is in southern India, actually in the province of Tamil Nadu. There, the cost per surgery is $30. So what is this then? What is this Aravind Eye Hospital? It was founded in the 1970s, actually 1976 in southern India. At the time, there were only 11 hospital beds. But it has grown over the last couple of decades and become an extremely efficient cataract surgery hospital. That's basically all it does. It just does cataract surgery. And it's able to do that so efficiently that it's been able to reduce the cost per surgery from the going rate of $3,000 to just $30. Now, how do they do that? The basic business model, and I use the term business model to divorce ourselves from traditional ways of thinking about the welfare state. The basic business model is that it's a high volume, what we call a high patient throughput model. They do lots of surgeries per day. As a hospital, for instance, it does approximately 300,000 cataract surgeries per year. Now, the way in which it does it, actually, is quite interesting. The way in which it does it is that in Canada, for instance, when you go in for a cataract surgery, your ophthalmological surgeon probably does 3 surgeries a week. And you go in and you have your pre-op, consultation, and then you sit around, and then you get ready for the surgery, and then the ophthalmological surgeon is doing whatever he or she is doing. They do the surgery, and then the post-op care is another day of sitting around in the hospital. Now, one of the things that we got a chance to do while we were doing this research is we got to actually watch these surgeries being done in the operating theater. Now, of course, we were up high, so we weren't contaminating down below. But the way in which they do it there is very interesting. Just as a very simple mechanism. They have 2 surgical tables. And as one patient is being operated on, the staff is prepping the next patient. And as I said, cataract surgery is actually very easy, as I saw, because they show the video. It's just a slit, and it's the insertion of a lens, an intraocular lens. It takes 10 minutes. So as the surgeon is doing this operation, once he or she finishes that operation, it's quite amazing. It's one of these chairs with wheels on it that can spin. He spins and does this one. And just goes back and forth and does these surgeries all day. And basically we have this extremely high volume throughput so that you're able to reduce the cost through economies of scale over time. Now, what's also interesting is 70% of these surgeries are free. So if you're poor, You don't have to worry about that $3,000 price tag. In fact, you don't even have to worry about the $30 price tag. The way in which the Aravind Eye Hospital does it is that they only charge those who are able to pay. And the only difference between those who are able to pay and those who aren't able to pay is in post-op care. If you can pay, you get a private post-op room. If you can't pay, you're in a room with 12 others. But the surgery and the lens is the same. So you're getting the exact same surgery whether you're a millionaire or you're a landless peasant. The only difference is the room in which you recover. And so therefore the cost per surgery is on average $30, but for 70% of patients at the Aravind Eye Hospital, it's free. Now the question is, how do they do this? Well, as you know, there are 12 million blind people in India. And most of them are located in southern India, so you have a market. But basically what they do is they do active patient recruitment. We saw this. They do eye camps, where they'll take a bus out to a village. They'll announce a few weeks in advance, we're coming to your village. And on that day, the hundreds of people line up. It's very easy to diagnose cataracts. You look for cloudiness in the eye. You diagnose it. You say, you've got cataracts, get on the bus. They used to let them go home for lunch. But when they went home for lunch, you can imagine 50% of them didn't come back. Because they're like, I don't think I want to do this. So they come, they get their eyes checked, and say, you have cataracts, get on the bus. We'll provide you lunch. And then they get the tens of dozens, or however many, they drive them on the bus, bring them back to the hospital, you conduct the surgery. They do these school screenings the same way. They go to villages' schools, and they do these active screenings. Easily and quickly diagnosed, get on the bus, go to the hospital, they do it through local clinics, and so on. How is this model sustainable? First of all, there is no government funding. This is why I want to stress, going beyond the state. There's no government funding for this. There's no donor funding for this. It's a self-sustaining business model based on a high-throughput system. The cost for surgery is reduced from an average of $3,000 in the United States to $30 in India, which allows for maximum affordability. How does it do this? Well, one is it manufactures its own lens. A pair of intraocular lenses in the United States will cost $500 US. The exact same lens will cost, in fact, the cost to make that lens is between $1 to $2. So if you actually eliminate that ridiculous profit margin, the actual cost to the end user is about $2. So they make their own lenses. They take advantage of volume and economies of scale, as I've already described to you. In the United States, a surgeon will do approximately 200 to 300 surgeries per year. In India and at the Aravind Eye Hospital, each surgeon performs approximately 3,000 to 5,000 surgeries per year. The US, 200 to 300, in India, 3,000 to 5,000. And as I've already described to you, we have a tiered fee-paying system in which the rich subsidize the poor, and in turn they are able to keep costs down. What we see, therefore, then, is a system that is A, equitable, it's accessible to the poor, it's sustainable because it doesn't rely on government funding, it doesn't rely on precarious donor funding, but rather it relies on a very innovative fee-paying system. And frankly, it's high quality. If you look at this table here, which was actually produced by the Royal Ophthalmological Society of the UK, you can actually see in terms of health outcomes, the Aravind Eye Hospital performs better than the National Health Service in the UK. Capsule rupture, this is an incident rate based on 22,000 surgeries. Capsule ruptures are half of that of the UK. Iris trauma, same thing. Anterior chamber collapse, and so on. The quality of the surgery at the Aravind Eye Hospital is better than the quality of the ophthalmological surgeries performed by the National Health Service in the UK. The key point here is that there are possible interventions that are beyond the state. There are possible interventions beyond the traditional welfare state. Just to give you another story, one of the things that we did in Taiwan, this wonderful group of former students, we spent 2 days in the mountains looking at Aboriginal health. Now, one of the interesting things in Taiwan is that life expectancy for Aboriginal males is 10 years shorter than the rest of the island. This is a tiny island. It takes like, 5 hours to drive the entire length of it. It's not a big place, and yet for some reason, Aboriginal life expectancy is 10 years shorter than those populations that live 100 miles away. The number one cause for premature deaths in Aboriginal communities is liver-related diseases. Actually, they're digestive-related diseases, which are liver-related diseases, which then epidemiologically goes back to alcohol abuse. So one of the things that when you're talking to health policymakers there, you say, how do we reduce alcohol abuse? And they'd say, well, as we hear often in Canada, that's just the way Aboriginals are. It's part of their culture. Right? So when you're actually in the field, now we're in the field, we're in the mountains, and we're talking in these mobile health clinics, and we're actually talking to real doctors on the ground. One of my former students asked, and I knew immediately where he was going with this. It was fantastic. He said, is there a bank here? No. Is there a post office here? No. Why do you ask these questions? Because in a post office, you can save money. You can open an account. In other words, then, he said, where is the nearest post office? 15 kilometers away. In other words, then, for these Aboriginal male workers, they have no place to save. Now, how do they earn their money? They're day workers. They stand by the side of the road, a truck comes by, and they'll pick 5 able-bodied workers, they'll go work for the day, they'll come back, they'll get their 500 NT dollars in cash. And who's standing right next to that truck as it's being deposited? Or as that truck is being unloaded, who's standing right next to it? An alcohol vendor. So here's the problem. You work in a purely cash economy, your regular wages, you don't know when you're going to get your next job, you have no institution in which to save money, and you have someone there pushing alcohol as soon as you get your first bit of cash. So what the students are now thinking, and what we're designing, again, beyond the state, working with the local, working with local organizations and NGOs, is to create a savings mechanism. Can we create a credit co-op, for instance, through the church to encourage savings, to hopefully discourage consumption on alcohol, and to hopefully then increase the health status, or better the health status of Aboriginal males in Taiwan. The point here is that these solutions are all local and they're non-state. Let me say again that in closing, we've seen inequality through 4 vignettes, 4 stories. The first was global inequality. The fact of the matter is, after the golden age of the post-war